This content is AI generated for informational purposes only and should not be directly used for clinical decision-making.
Hello and welcome back to the Neurosurgery Hub podcast. I'm Dr. Aris, Senior Attending Neurosurgeon.
And I'm Dr. Alara, Research Fellow. Today we're looking at a fascinating new study from the University of California, San Francisco, published in the Journal of Neuro-Oncology. It's a comprehensive review of the UCSF protocol for intraoperative functional brain mapping in glioma surgery.
This is a timely paper, Alara. We've seen a significant shift in how we approach diffuse gliomas. It's no longer just about the contrast-enhancing core. The gold standard has evolved toward maximal resection of both the contrast-enhancing disease and the non-contrast-enhancing flare borders.
Exactly. And for IDH mutant astrocytomas and oligodendrogliomas, the authors emphasize supratotal resection, going beyond the flare margin, because it correlates with lower risks of recurrence and longer overall survival. But as we know, the more aggressive we are, the closer we get to functional eloquent tissue.
Right. And the paper makes a very strong point about the trade-off. We cannot compromise functional status for the sake of extent of resection. They mention the oncofunctional outcome, or OFO classification by Gerritsen. Alara, could you break that down for our residents listening?
Of course. The OFO scheme is a way to look at the balance. OFO1 is the goal, complete resection without neurological deficits. OFO2 is incomplete resection without deficits, and OFO3 is complete resection with deficits. The study found that OFO1 patients had the best outcomes, with a median survival of 19 months. Interestingly, OFO3 patients, those where the surgeon achieved a total resection but left the patient with a deficit, had similar survival to OFO2 patients who had residual tumor but stayed intact.
That's a powerful argument for mapping. It proves that a deficit can negate the survival benefit of a gross total resection. And the paper notes that OFO1 is most commonly achieved when intraoperative motor or language mapping is utilized.
Let's dive into the UCSF protocol specifically. They've refined this over decades. One of the core pillars they discuss is the negative language mapping paradigm for awake craniotomies.
This is an important distinction. In their protocol, they limit the surgical exposure to the boundaries of the tumor itself. They aren't necessarily looking to find and include positive mapping sites, the areas that cause speech arrest, beyond the tumor. In many cases, they might not encounter any eloquent tissue at all. That's the negative mapping concept. If you map the area of intended resection and find no function, you proceed safely.
And to do that, they use a specific stimulation paradigm. For language, they stick with the awake setting, using low-frequency bipolar stimulation, often referred to as the Ojaman stimulator. But for motor mapping, they've actually transitioned their practice significantly.
Yes, the shift from awake to a sleep motor mapping is a major highlight of this review. Why did they make that change, Alara?
Several reasons. First, it improves patient comfort. Second, it minimizes the background noise you get in an awake patient. But technically, the biggest advantage is that asleep conditions allow for what they call triple modality motor mapping. This includes transcranial motor evoked potentials, or MEPs, which just aren't feasible in an awake patient because the stimulation is too painful.
And that triple modality is key. They aren't just using one tool. They combine high-frequency monopolar stimulation, low-frequency bipolar stimulation, and those transcranial MEPs. Using both monopolar and bipolar stimulation allows them to maximize the advantages of each while offsetting the limitations.
Let's get technical for a moment for the residents. The paper describes the high-frequency monopolar stimulation as being very effective for subcortical mapping, tracking the descending cortical spinal tracts, while the low-frequency bipolar is classic for cortical mapping.
And they also address the supplementary motor area, or SMA. This is often a point of debate. Do you map the SMA awake or asleep?
UCSF stance is clear. They prefer a sleep mapping for the SMA. They found that awake mapping in the SMA can actually lead to premature termination of the resection. The patient might start showing signs of SMA syndrome intraoperatively, and the surgeon stops, even though we know that postoperative SMA syndrome almost always resolves. By mapping it asleep, they can achieve a more radical resection, knowing that the resulting temporary deficit won't significantly affect the patient's long-term quality of life.
It's about knowing which deficits are permanent and which are transient. Now, let's talk about the before and after. The protocol starts long before the skin incision.
Right. They utilize a heavy suite of preoperative imaging. This isn't just standard MRI. They integrate magnetoencephalography, or MEG, to locate functional cortex, and diffusion tensor imaging, or DTI, to map out those critical subcortical white matter tracts. All of this is uploaded into the neuronavigation station.
I like how they describe the intraoperative process as a constant feedback loop. As they approach functional pathways in real time, the decision to continue the resection is based on the mapping findings.
If the MEPs drop or they get a motor response at a low threshold subcortically, they know they've reached the functional boundary.
And they mentioned troubleshooting. Mapping isn't always straightforward. You can have seizures from the stimulation or shunting of current through irrigation fluid. The paper emphasizes keeping the field dry and being prepared with cold saline for any intraoperative seizures.
Let's touch on the post-operative phase. How do they define success?
They use a combination of early postoperative MRI to assess the extent of resection and clinical exams. They are very focused on predicting whether a deficit is temporary or permanent. For example, if a patient has a new motor deficit but the MEPs remain stable and the subcortical mapping showed they were at least 5 to 10 millimeters away from the tract, they can be much more confident that the patient will recover.
This paper really reinforces that intraoperative mapping is the accepted standard for identifying pathways and avoiding iatrogenic injury. It's moving from an extra step to a fundamental component of glioma surgery.
Definitely. They conclude that by using these refined methods, the awake negative language mapping and the asleep triple modality motor mapping, surgeons can achieve that goal of maximal safe resection, even in the most challenging locations.
It's a great roadmap for any neurosurgeon looking to refine their technique. Alara, any final thoughts on the technical specifics?
Just the importance of the low-frequency versus high-frequency paradigms. The paper notes that using both provides a safety net. The high-frequency monopolar stim is great for continuous feedback during subcortical dissection, which is often where the most critical decisions are made during the final stages of tumor removal.
Well said. This has been a deep dive into the UCSF protocol. For our listeners, the key takeaway is that maximal resection and functional preservation are not mutually exclusive, provided you have the right mapping tools and the expertise to interpret them.
Thank you for joining us on the Neurosurgery Hub podcast.
We'll see you next time.